Ganesh,
Yes, sir.
huh. Let some few more people come and Vijay Patil join. We start it.
Sure, sir.
Huh? Today, who is answering?
Good evening, sir. Sir, I'll be answering. Shashwat.
Saswat. And who else is there?
And Sir Dr. Mikhala.
Pardon?
Sir Dr. Mikhala is also answering, sir. Dr. Shashwat sir and Dr. Mikhala.
Okay.
Good evening, sir. I'm Dr. Miraj. I'm also answering.
Okay. So you are answering?
Yeah.
Fine. So we just wait for 2-3 minutes. I think Dr. Patil, once he joins, we start it. Ganesh, you have talked to Dr. Vijay Patil, na?
We will start with case till Dr. Vijay Patil join because it is already 9:15. Sir.
Okay, we start then. I'm just calling Dr. Vijay Patil only. I
He
think
will
Ganesh,
join in
Ganesh knows
between.
it better. We start it now.
Yeah.
Dr. Ganesh. Ganesh has already joined. Ganesh. Because in this case, Ganesh has given cases. So, you know, he will be like a moderator.
Yeah. तो पेशेंट आया था क्या सर आपके पास?
या आ गया, सब नक्की हो गया है. हाँ
ठीक है, ठीक.
सब फाइनलाइज कर दिया मैंने उनके साथ में. ओके. Once Ganesh.
हाँ सर, मैं रेडी हूँ.
Okay, then we start. And you talk to Vijay Patil, ना?
मुझे आज नहीं बात किया, मतलब कल रात को बात किया था. सेम.
हाँ, कल रात को बोला था ना?
Yes sir.
Yeah, because I am trying to call him.
मैंने फोन नहीं किया.
Okay.
बोलता हूँ.
Okay, then we start the case then.
Good evening, everyone. We'll start with the first case. Sorry, sir. Wait. One minute, sir. Yes, so the first case is a 50-year female presented with complaint of pain over left side of abdomen for a period of last 1 month.
Okay, Sashwat, go fast. We will not interrupt you much. What are the important points you will ask?
Sir, I'd like to ask about the site, onset, severity, duration, progression of the pain, then the radiation of the pain, associated factors like fever, lower urinary tract symptoms, any hematuria, lithuria, and along with that, sir, the any diurnal variation or relation to aggravating or worsening factors for the pain.
Okay, so we will not discuss much. We'll go ahead. Just tell the history.
Okay, sir. So pain was dilated in nature, non-colicky, insidious in onset, non-radiating, gradually progressing, and no specific aggravating factors are there. And the pain was relieved on taking analgesics. There was no history of burning, micturition, no history of fever, no history of pain, no history of vomiting, no history of hematuria, lithuria, no history of increase or decrease in frequency, no history of facial puffiness, exertional breathlessness, no lower limb edema. Patient had no comorbidities. Family history was non-contributory. And diet was, patient takes a mixed diet. Appetite is slightly reduced over last 1 month. Bowel is regular. Bladder is normal. Sleep normal, and habits. Patient is non-alcoholic, non-smoker, non-tobacco chewer.
Yeah, Sashwat, you want to ask anything in particular, important, keeping urology in mind?
Sir, any hematuria, lower urinary tract symptoms?
No, that he said everything is
Yes, sir.
absent. So nothing is nothing important is left, na?
Yes, sir.
Okay, go ahead.
On general examination, patient was conscious, cooperative, well-oriented, time, place, and person. Pulse was 70 per minute. ECOG status was 1. BP blood pressure was 131, 80 mm mercury, respiratory 18. Patient was afebrile, saturation 90% room air. There was no evidence of pallor, eclair, pharyngeal, lymphadenopathy, or edema. Spine examination was normal from head to toe. For abdomen, on inspection, flat abdomen, centrally placed and inverted, and blackness was there. Normal abdominal thoracic respiration, skin and had no scars, sinus or dilated veins, no visible swelling was there on this, and no visible peristalsis or pulsation. Onion sides were clear and external genitalia was normal. On palpation, the temperature was normal over the skin, over the abdomen, no tenderness, and ill-defined palpable in left flank below the costal margin, separate from it. Left iliac fossa and up to the umbilicus majorly. It was measuring 10 into 7 centimeter with indistinct margins of firm in consistency. It was bimanually palpable and palatable. It was moving with respiration. Fullness of left renal angle was there. Hernial orifices were normal. There was no cuff impulse, and external genitalia was normal. Spine, there was no deformity or tenderness over spine. On percussion, there was resonant note over the lump, and the rest of them was tympanic. Renal angle dullness was there. On auscultation, there was no bruit. Bowel sounds are normal, and DRE was no anything. So the positive finding was ill-defined lump in the left flank, which was moving the respiration with indistinct margins and firm consistency.
One single question. Lump clinically palatable and moving with respiration. What is its clinical importance? Only 2 words. What is the clinical importance in this patient? Palatable and moving with respiration. Which lump is palatable?
Sir, retroperitoneal renal lump is palatable, sir.
देखो, moving with respiration and palatable, it indirectly suggests that this lump is not fixed.
Yes, sir.
Correct? If this lump is fixed or involving the surrounding structure or probably retroperitoneum, then it will not move.
Yes, sir.
Or it will not be palatable. It will be only bimanually palpable. So whatever may be the clinical stage of that lump after CT scan, we will see. But usually it looks like a locally movable and free from the surrounding structure.
Yes, sir.
Okay.
So can I go ahead? Sir, on clinical exam, on labs, hemoglobin is 11, total count is 8,000, platelet was 2,10,000, and creatinine was 0.90. And after this, there's an imaging was done, sir. Imaging, Mr. Souza.
Hello, let us ask them what are the investigations they want.
Sir, a complete urine examination and an ultrasound abdomen and pelvis, and followed by, sir, multiphasic contrast and CT scan of the abdomen and pelvis, sir.
So what you are here suspecting?
Sir, I'm suspecting a renal mass, probably a renal malignancy, sir. Along with that, sir, my other differentials could be, sir, PUJ obstruction, sir, and
We are asking you after the examination, huh?
yes, sir.
So in that case, what are the investigations you'd like to have?
Sir, in preliminary ultrasound abdomen and pelvis, sir, I'd like to request.
Okay. Showing.
Sir, we had a CT scan done. This was the imaging picture, sir. CT abdomen and pelvis was done, sir.
Show him all the films.
This is the only, sir. These are the two pictures that we have.
Okay.
Left renal mass.
Yes, you want to comment on that, Sash?
Yes, sir. Sir, the images projected, sir, of the contrast enhanced CT scan of the abdomen. These axial sections, the one on the left, sir, it shows a large heterogeneously enhancing, sir, mass in the left kidney, sir. Left kidney is grossly enlarged, sir, and I cannot appreciate, sir, any lymph nodes or any extrarenal extension. Seems to involve the whole of the kidney, sir, in this section, and the contrast, I cannot see, sir, any excretion in this phase, and the right kidney, sir, appears normal, and on the right hand side, sir, it appears contrast enhanced imaging of the section of the chest. It shows, sir, a subpleural nodule on the left side, sir. No other effusion or anything I cannot make out, sir.
So Ganesh, can you just take over?
Bolo sir, I can. Okay. I was just talking to Vijay. He is unable to join because he's having a patient in ICU.
Okay.
उसका कोई patient अभी shift हुआ है तो he is sitting there. He said कि थोड़ा difficult to join.
अच्छा.
ठीक है. So ये last part थोड़ा miss किया मैंने. I was talking to him actually.
Yeah. So Shashwat, you can just describe again.
No,
Just
don't
tell
describe again. मतलब whatever. These are representative images basically. You can see a left renal mass and you can see lung which shows something. So how would you go about it?
Yeah, Mehraj, you can answer. What do you like to do now?
We would quite sometimes see a patient like that.
Do a remaining metastatic work to see where all the metastases are. That is an ALP level, LFT, and I want to do, if there is any ALP positive, then I want to do a bone scan, or directly I can do a PET scan for this patient.
So I agree with the last part what you said, that you would do a PET scan, but the initial part you said, if ALP is positive, then only I will do a bone scan is the wrong thing. Okay, so when we have localized renal cancer, in those patients, as a standard method by European guidelines, at least, I've not read the USI guidelines, honestly, we do a CT chest. And if the alkaline phosphatase is high, then we do a bone scan, or we are supposed to do a bone evaluation. Here, the patient is metastatic. When we know that there is a metastasis, even if that patient's alkaline phosphatase may be normal, but you are supposed to evaluate the bone. Now, how you do it is your choice. Here, the CT chest, abdomen, pelvis looks to be done. So you might add a fluoride PET, or then straightforward do a FDG PET CT scan. I hope the point is clear. There are two different scenarios. One is you say all that alkaline phosphatase is high, I'll do this, that. That is all in localized scenario. Here, you said very right sentence in the beginning. I'll find out if there is other metastasis, another METS or whatever. Basically, the burden of metastasis. And the simple reason why we say that and why I support that. Many people say कि अभी टेस्ट किया है CT, उस पे METS मिला है तो ट्रीटमेंट में क्या फर्क पड़ता है? This is a very common sentence said by many doctors. So there itself is a mistake in that. You need to completely document where and how many metastases are there. Otherwise, tomorrow I give therapy to this patient, I will really not know what is the. Okay.
I think Ganesh, you have made a very clear point, because even many consultants also, as a consultant, I will also not think in the same way as you are thinking.
No, so that's why I say that, because I see many of these patients seen by other people and common mistakes are happening like that.
Fine. So if there is metastasis, it is always better to do a better workup to find out the total number of metastasis and where it is, which are the places it has gone and the number, correct?
Yes,
Fine.
yes.
Okay, Shashwat, so this is the case. So now you want to know what about the PET scan?
Yes, sir. If available, yes, sir. Complete metastatic workup.
Swastik, you have done? You got it?
Sir, CT, first of all, the CT report was a 12 into 11 centimeter lesion on the upper and mid part left kidney with rectopetal nodes and solitary permanent nodule. And then, sir, so questions are there. And no, sir, this
So
was
these are the, yeah.
this was the only thing sir, that was missing. Yes, sir. In this case, sir.
So
Yeah.
there are
Ganesh,
theory slides. There are theory slides on this presentation, but you leave that. What will you do with such a patient now? That's it.
Sir, we will counsel the patient about the investigations and the reports which we have obtained, sir. And we would like to risk stratify the patient as it is a case of metastatic RCC, so that we can have a multidisciplinary approach and discuss the further line of management and the therapies that we can offer.
So, any risk stratification methods, you know?
Yes, sir. Sir, there are MSKCC Memorial Sloan Kettering Cancer Center or the International Metastatic RCC Database Consortium Risk Stratification System, sir, which uh, uh, which stratify the patient into favorable, intermediate, and poor risk disease. The IMDC risk stratification includes the Karnofsky performance score less than 80%, and the interval to diagnosis and treatment, if it is less than 1 year, then it is a poor risk. Then if the corrected calcium level are more than 10.2 milligram per deciliter, hemoglobin is less than the lower limit of normal, and the platelets are more than 4 lakh or upper limit of normal, and neutrophils are also more than upper limit of normal. If none of these are positive, sir, it is a favorable risk metastatic RCC. If 1 or 2 are positive, then it is intermediate, or if 3 to 6 are features are positive, then it is poor risk metastatic RCC.
Okay, so basically you need a scoring on that.
Yes, sir.
And on the basis of scoring, we give the risk stratification. So when somebody asks you a question, technically, we don't do calcium usually as surgeons.
Okay.
So you remember that. I mean, we should say that I would do these investigations, and probably I would stratify according to IMDC classification.
Yes, sir.
So you said about 3 risk stratify attacks, and then how will you decide treatment?
Sir,
Rakesh, make Mahendra Pal co-host.
sir, if she's a 50-year-old female, sir, and her ECOG status is 1, and apart from that, sir, if she falls into the favorable risk category, sir, then she appears to be oligometastatic disease patient, sir. So with favorable risk, sir, we can offer a cytoreductive nephrectomy with metastatectomy.
Okay. So
If she falls into the intermediate risk, sir, then we would like to discuss it with the patient and offer her, sir, immunotherapy combination
so see,
systemic therapy.
okay. So you know something, when you get 0 points in the IMDC,
Yes, sir.
then only the person is going to get favorable risk. Okay. Am I right?
Yes, sir.
Yeah, I'm right. So if you actually see the IMDC, the first criteria will say less than 1 year from the time of diagnosis to systemic therapy. So
Yes,
this
sir.
criteria seldom is going to be 0. Okay. In a de novo diagnosed MRCC, that criteria is not going to come.
Okay, sir.
So we actually find very, very few 0 IMDC score favorable patients. In most, the scoring can happen, favorably to the surgeons, if I say so, it is +1. +1 in the sense, 1 point.
Correct,
Okay.
sir.
So again, saying that sentence, less than 1 year from the time of diagnosis to systemic therapy. So remaining can be 0 more usually. And then there are enough literature which say that even when we have a favorable or an intermediate risk with 1 point, in that case also we probably should offer cytoreductive nephrectomy if operable, and then give systemic therapy. But if patient falls in intermediate risk with 2 points, then technically the median survival goes down, and then technically you don't do a cytoreductive nephrectomy.
Okay, sir.
You do something which is probably, I call it as deferred cytoreductive nephrectomy. You don't do a upfront cytoreductive nephrectomy. I hope you got the difference between the two.
Yes, sir.
So I spoke something which is something like upfront cytoreductive nephrectomy and something which is called a deferred cytoreductive nephrectomy. In between, there will be a role of systemic therapy. Okay.
Yes, sir.
Fine.
If you guys finding difficult to do the MDC scoring, it is available on the Google on MD calculator. That's a very easy scoring to use in actual life. So anything, otherwise, you can tell us about something like, suppose if this patient would have got solitary metastasis,
Yes, sir.
what would you have done?
Surgery first, metastatic, followed by systemic therapy. Yeah, followed by.
Why? But what kind of evidence we have for all doing that?
Sir, in
So
field.
I'll explain you a scenario. Right renal mass, left renal mass, as we saw, with something like single metastasis in the right lower lobe of the lung. But if I do the scoring of this patient, IMDC scoring, his platelets and his neutrophil count wise, he comes in the category 2.2 points, score of 2, which is intermediate risk. Technically, we call it. So what will you do? And why? You are going to see these patients tomorrow in practice. So you need a very clear thought in mind how to take care of these patients and how to counsel them. So Miraj, when you talk about, when somebody asks you a question of metastatic, again start that, sir, I'll do a counseling of this patient, he having metastatic disease, and then offer so, whatever you want to. Bully, Sashwatji.
Yes, sir. Sir, I'd like to counsel the patient and obtain a multidisciplinary meeting and discuss the.
Meeting में हम लोग ही सब हैं. Please. So today you will have to be the multidisciplinary committee head of the department.
Sir, in intermediate risk with 2 risk points, with oligometas.
Oligo, I'm saying solitary. Oligo is different. Oligo will go
solitary METS.
Kidney में oligometastasis का अभी तक कोई खास meaning नहीं है.
Yes, sir.
If I have one metastasis in the humerus, one metastasis in the brain, we don't call it oligometastasis. Neither do we call 3 metastases in the lung as oligometastasis, by the way.
Yes, sir.
The oligometastasis term is well defined in CA prostate, where we say up to 5 can be oligometastasis.
Sir, given the performance status of the patient, sir, 50-year-old and ECOG1, we can offer either upfront immunotherapy-based systemic therapy, followed by assessment of the response and a deferred cytoreductive nephrectomy with metastatectomy. Or if the patient wants a cytoreductive nephrectomy with metastatectomy. That can also be offered first.
पेशेंट वांट्स का कोई सवाल नहीं रहता है ना, पेशेंट तो आपको ही पूछेगा डॉक्टर साहब कि आप क्या करेंगे.
It is less morbid if we do a surgery first and then follow it up with the systemic therapy.
Okay.
Sir, I think systemic therapy first.
क्या करने वाला है first?
Sir, I think systemic therapy must be offered first, sir.
Surgery.
So what happens is, see, whenever there is a solitary metastasis, usually we consider it as a slightly different biology. And then we would probably offer surgery. Although I would explain the patient that this is stage 4 disease and whatever scan you do, PET scan or something, is probably detecting only one metastasis site. It's better to be clear about the patient, because next time he does a PET scan, there will be 4 sites. So it's best to use this line that right now, investigation or imaging wise, you look to have solitary metastasis, in which we can render these patients probably R0 resection if we do the primary surgery as well as the surgery of the metastatic site. However, we still label them as metastatic with no disease currently. Now, to such patients, starting any kind of therapy is a big question because there is no great data. Metastatic patients usually receive something which is called as, finally we call it palliative chemotherapy, palliative targeted therapy. Conveniently, we don't use the term into bracket palliative when we are offering treatment to these metastatic patients. Okay.
Yes, sir.
Now, what happens is there is a pembrolizumab trial which was used with as an adjuvant therapy in RCC. I don't remember the number of that trial, 524 or something. Keynote. So, in that, there was a cohort of patients which was similar patients who were operated and then rendered M0. M0 after the surgery. So these patients were apparently in the setting where they received benefit with 1 year of pembrolizumab. Otherwise, there is no hard fast thoughts on that. I would also support your opinion beyond that, that it needs to be seen by multidisciplinary tumor board. Okay.
Yes, sir.
Secondly, not only solitary but renal cancer. Suppose if I have 3 metastatic nodules in, say, right lower lobe lung with a renal mass, I would still operate the renal mass and also do a lobectomy of the lung, because that gives my patient R0 resection. At that moment, he'll be cancer free. I don't know how many circulating tumor cells will be in the circulation, which will in future may or may not grow when they land up at different sites. I don't know that. But at that moment of time, he'll be tumor free. And then, as I said, the data is there with pembrolizumab therapy in such cases where you can still give pembrolizumab and try to kill the circulating cells. That's all I wanted to say. Mahendra, you were asking something.
No, sir.
You want to say anything extra? Any suggestion?
No, just whatever sir said. If you have any plan in your mind for the patient, you should know what is the scientific basis of that plan, that you can explain to the examiner and to the patient. And definitely, the most confusing part in this classification is there is no T staging included in this, right? So you have to see the clean disease burden as well as the patient fitness and the MDC and MSKCC criteria, and you have to balance it between these two to decide the treatment option and whatever the trial it is there available to quote the same of the treatment. And as sir said, upfront surgery, deferred surgery, and palliative nephrectomy, the other 3 terms can be used in this scenario. Okay. and you have to just decide based on all these factors. Even if the patient is kidney is very operable, maybe feasible for nephron sparing surgery, and having multiple METS and having a you can say the favorable intermediate risk, right? So again, the approach is different. And here definitely the MDTT approach is good.
So few
Okay.
points to remember is you should always try to risk stratify, do the investigations which are there in the risk stratification requirement. Have the IMDC scoring which is currently used. There is a lot of literature in future coming up with even modification of IMDC scoring with integrating of few other things like Dr. Mahendra was saying. We may get those data in another year probably. People will publish it to make the whole scoring more clinically oriented, incorporating IMDC with some other factors. And then about solitary metastasis or other resectable disease, if we should say that. Then upfront cytoreductive nephrectomy, and the other is deferred cytoreductive nephrectomy. That's important. If there are any more slides on the presentation, you can go ahead. I think some slides are theory also.
Yes,
Yeah,
sir.
you can go ahead.
So I don't know.
Yes, mention. Yes, sir.
So, okay, IMDC scoring we have discussed, right?
Yes, sir. Management of this patient was there, sir.
Anything else here?
So cytoreductive nephrectomy, template nodal clearance and left lung metastatic. And then histopathology of P4N1 and cell clear cell forming grade 4.
Yeah.
And then sir, theory part is there, sir.
You can read that if you want, please.
So to simplify the things, it is a performance status of the patient, number of metastasis, site of metastasis, resectability of metastasis, resectability of local tumor. Okay, this all factors you have to take into consideration and decide the treatment. If it is a poor performance or poor risk patient, there is no role of cytoreductive nephrectomy. If it is a good performance status or good risk patient, favorable risk patient, it is upfront cytoreductive nephrectomy. If there is intermediate patient, then systemic therapy with deferred cytoreductive nephrectomy. This is just simplified algorithm like thing to keep in the mind. Okay, if it is the three metastasis, one place, resect it. Three metastatic, different place. Symptomatic or asymptomatic, again another criteria. Okay, so if it is brain metastasis, if it is bone metastasis isolated, then what is the treatment? What is the role of radiotherapy? Then radiotherapy, again it is stereotactic surgeries plus radiotherapy, complete external beam radiotherapy, immunotherapy में with sunitinib, without sunitinib, ये सब चीजें पढ़ना. लेकिन सिंप्लीफाइड अगर एग्जाम में बताना है तो ये सब 4-5 चीजें ध्यान में रख के रिसेक्टेबल है कि नहीं और परफॉर्मेंस स्टेटस क्या है, ये 2 पॉइंट पे ध्यान रखना और वो हिसाब से बताना.
Fine. So in this case, how will you go about after doing the nephrectomy and cytoreductive surgery is done and then even the metastasis has been removed? So Sashwat, how will you follow and what you will do? The slide is in front of you, so you tell us how will you follow and what you will do. You can read the slide and you can answer.
So clinically, now the patient is R0,
Yes, sir.
right? You cannot, in this fresh CT scan after 2 months, there's a no disease recurrence and no disease evidence. So it is like a disease-free patient radiologically.
Sir,
Mhm.
as per the EAU guidelines, sir, if it's a favorable risk patient and we have obtained a clinically M0 after cytoreductive nephrectomy and metastatectomy, the role of systemic therapy is not very, there is not a strong evidence of giving systemic therapy now. So, and I think we should keep the patient in regular follow-up, sir. 6 monthly, we can get a PET scan and then we can follow up, sir, 6
So
monthly.
why is it so? You don't want to start targeted therapy or immunotherapy for this patient? There's a reason behind it. You are right, but you should know the reason.
Sir, I think if the tumor seeding circulating tumor cells have not implanted and grown till now, there is a lesser and lesser chance of
So the
new
answer this question would be there's something is called a spontaneous regression of the tumor, and RCC is one of those tumor which immunogenic tumors actually, right?
Yes, sir.
So if you remove the all visible disease, okay, so immunogenic response take care of rest of the tumor cells. And
Yes.
and the evidence, the reason is behind it. You should not start the targeted therapy immediately after achieving the R0. And also there is a literature shows that if you start targeted therapy immediately and you observe when the recurrence, there's a no benefit, the OS benefit and recurrence-free benefit in those patients.
Yes, sir.
Right? So
Yes.
it can reduce the toxicity of the drug, okay, without affecting the overall survival.
Yes, sir.
Okay, these are the two answer for this question. Okay.
Yes, sir.
Right. Carmina trial. Tell us something about it. Slide is there.
Sir, in the Carmina trial, it is a trial between cytoreductive nephrectomy first, followed by sunitinib or sunitinib alone in intermediate to poor risk metastatic clear cell RCT patients, sir. They found that it was a non-inferiority randomized control trial. They found that sunitinib alone was not inferior to cytoreductive nephrectomy followed by sunitinib, sir. In intermediate to poor risk.
Poor risk, right?
Yes.
Good. So this is the main conclusion of this trial that can be that generally nowadays it is used for deciding the patient about the post for the nephrectomy, nephrectomy. Okay.
Yes, sir.
Okay. So suppose that this patient we achieve R0, and after 16 months he has some humerus shaft lesion of 1 centimeter.
Yes, sir.
What will you do?
So I think we can offer the patient a close follow-up of the.
Now he has recurrence, biopsy proven recurrence.
Excision
After
of
2 years.
metastatectomy.
Why not TKI? Why not systemic immunotherapy and any therapy, system therapy?
Sir, because if we assume that the bulk of the tumor has been reduced, has been taken out of the body, and only in the past 16 months, sir, there has only been seeding at one point. So it is unlikely that other tumor, if seeding would have happened, they haven't grown till now. So that could be the reason, sir. Only one place has had metastasis.
Yeah, it is. If it is operable, it's feasible to remove it. for the again single recurrence after the a
Yes,
long gap. Okay.
Yes, sir.
Right. Yeah. Bakshi sir, I think all trials are, you should know all these trials, which are time, assured, extract trial for adjuvant and neoadjuvant therapy. You should know about these trials. Okay. Even no trial is proven to be very effective and to be taken in guidelines. Okay. But you should know about these trials. Okay.
Yes, sir.
Sir, anything
You
else?
can just, Mahendra, you or Ganesh can just, in short, can tell about this trial and that conclusion. So,
So which trial is this?
Sir, time, sir. Sir, time trial, sir.
Okay. So I think this trial also did not show so much overall survival benefit too much. I don't think so. Deferred and immediate about sudden nephrectomy. It has all has some biased these trials, so much biased. So they are not taken into consideration. Exactly detail really I do not know. Vijay Patil was have thrown some knowledge light into it. Definitely for this reason, for the biasing reason, this trial and the assured trial, they're not taken for in the guidelines with much weightage. Abstract trial shows some new adjuvant setting, but again there are some biasing is there, so it was also not so popular. Even we started giving patient adjuvant therapy, but again we stopped using. Bakshi sir, want to add something?
So, Mahendra, if
Yes.
after 1.5 years, okay, if the
Mhm.
patient develops a single metastasis, then again we offer the surgery.
Yes, sir. If it is operable without any causing much more morbidity.
Okay.
Suppose that if it is in the brain, we can give radiation, and if it the maybe liver, we are unresectable near the portal nodal area, something that part that definitely we can again plan RF if it is feasible. We can avoid systemic therapy in that.
Okay.
Yeah.
So again, it depends upon the different sites, and accordingly that we can offer
Yeah.
them either surgery or radio frequency or radiation.
Yes, sir. Because main aim is to achieving R0 if possible, whether surgical removal or by the RFA or the cryo, if it is possible. If it is not, then we have to treat the patient by systemic therapy.
Okay, so then you go for a chemotherapy.
Yes, sir. Either immunotherapy or TKI.
Okay, fine.
Because chemotherapy has no role in clear cell carcinoma. Okay, other than this thing, other pathology like ductal and medullary carcinoma, there is a role because their immunotherapy and TKIs had no much role in that.
Fine. Swastik, just go ahead and finish the slides.
Yes, sir.
So someone can read this slide which, yeah.
So this shows the changing paradigm over the years in treatment of metastatic RCC. So from sorafenib and temsirolimus, sunitinib, then went up ahead to bevacizumab and interferon alpha, limus and pazopanib. These days, pembrolizumab plus axitinib, ipilimumab plus axitinib has also been taken up, and immunotherapy with ipilimumab and ipilimumab is also coming since 2018. So this is
Yeah. So if you see the EU guidelines, there is a very nice chart as per the risk criteria, because in a favorable risk, if surgery is possible, we should go with the surgery. IMDC score 0, and if it is not, again this thing, there is a sequence of treatment is there in EU guidelines. So please go through those. So one is standard of care, which was TKI previously, now it is immunotherapy, first line. Okay.
Yes, sir.
Yeah. Please go through that table.
Table, sir. Okay. So, looking out at the critical analysis of Carmina trial, it included intermediate poor risk patients as discussed, accurate, that is less per year per center and incomplete, which reflect environment and selection bias. Previous retrospective studies had already indicated that poor risk patients don't benefit from cytoreductive considerable shorter overall survival in both arms compared to previously similar cohorts. And median size of primary was 88 millimeter and median total tumor burden was 140 millimeter. So metastatic disease contributed 40% to the total tumor burden in these patients. Thus, cytoreduction in true sense was not possible for many patients due to cytoreductive nephrectomy because 40% was total tumor burden from the metastatic disease only. So these were the critical analysis of Carmina trial.
One more thing it is there because they included those centers which do hardly 5 to 10 nephrectomy in a year. So that's why there was also selection bias in this trial.
So going to critical analysis of certain trial, it was also poor accumulator. Only 99 patients were there in the trial, and 19% of the patients did not receive the therapy that they were assigned. So as discussed, the site of the metastasis, patients with single liver metastasis or 10 lung metastasis fall in the same MSKCC and IMDC risk category if they have similar lab values, but these patients are not the same. So this study, the REMARK study showed that the presence of more than 3 sites of metastasis and presence of liver mets is significantly associated with poor survival. So this chart shows primary clear cell metastatic RCC. Then there are whether the patient is symptomatic of local tumor or patients have no symptoms of local tumor. Patients who have symptoms of local tumor and have intermediate will have immediate cytoreductive nephrectomy and further treatment according to metastatic extent and IMDC risk group. And patients who are not symptomatic of local tumor with poor performance status can be offered systemic therapy, and good performance status requiring systemic therapy or not requiring systemic therapy. So those requiring systemic therapy are more than or equal to 3 IMDC factors. We will give systemic therapies, 2 IMDC factors systemic therapy, and deferred cytoreductive nephrectomy if there is no progression, and 1 IMDC factor we will give them immediate cytoreductive nephrectomy, then systemic therapy. Patients who do not require systemic therapy, we will give them immediate cytoreductive nephrectomy plus metastatic if all regions are resectable. So we will remove the metastatic regions, and then patient will be followed up with the surveillance. This has already been discussed by sirs.
Remember that those guidelines only for the clear cell carcinoma.
This is also clear cell metastatic.
Okay. Yeah. And papillary cell carcinoma has a different approach of medication. Again, it is given in very nicely given in guidelines as a tabular form.
So coming to the question of lymph node dissection in cytoreductive nephrectomy, this study of lymph node dissection not associated with improved survival among patients undergoing cytoreductive nephrectomy for metastatic RCC. A propensity score-based trial was done. It was done in pre-TKI oncologic benefit of lymph node dissection in the overall cohort of patients with N1 RCC, and nor among the high-risk subgroups, patients with cytoreductive plus or across the increasing threshold probabilities of PN1 disease. So this study was done in pre-TKI era, and they showed no overall benefit of lymph node dissection in these in patients with undergoing cytoreductive nephrectomy.
So Ganesh, you want to comment anything on the lymph node dissection in RCC? Any advice?
Sir, in metastatic, it has not proved in long term to be beneficial.
So we should not, unless and until, means you say that if there are any enlarged lymph nodes, only those should be removed nearby.
You should. So it reduces, see, the whole logic of doing a cytoreductive nephrectomy is in its name, cytoreductive for cancer. So you remove the cancer once, there is nothing like, it reduces the burden. But it doesn't cause overall, probably change in overall survival.
Okay.
If we remove the lymph nodes which are there in the hilar region, if we leave them, suppose tomorrow they grow, they will erode the duodenum, cause problems. So that way you can remove them without expecting that it will cause a survival benefit.
So basically, they are removing it for the decrease the complication related to the enlarged lymph node.
Whatever easy to remove, it's better to remove. But underlying thing is that you are not going to improve survival by evidence.
Fine. Okay. So anything else, Ganesh, you want to advise them? Otherwise, your second case, we can just go ahead and discuss it out.
No, sir. Yeah, अच्छे slides है सब. These slides open up everything like.
Yeah.
अपने
So,
slides.
Yeah. So can you just, you or Mahendra can just explain about this? About this.
Okay. So I think it is a clear no, nothing to explain. So this is the as per the risk stratification, the first line, second line, third. Any drug can be given out of the preferred regimen, but it should be in combination. This is not a single regimen, the drug. So either immunotherapy plus TKI can be given, and axitinib with pembro, cabazole with nivolumab, and libitinib with the pembro. So this is the combination has been studied, and they prove beneficial in this setting. If you see the poor risk, this one the sequence is similar. Only one combination is added, is ipilimumab. Only these things you should remember. The second line, other regimen, if patient is not fit for immunotherapy, then only other therapy can be given. Not a drug is not available. Of the last slide, if you see the last column, useful in certain circumstances. Okay, active surveillance, axitinib category B, high dose immunotherapy. But again, these circumstances should be defined over there. Really, I do not know what are these certain circumstances. Maybe patient is having very small disease burden and kept on not active surveillance. I don't know how they write in the M1 disease as active surveillance. Okay, and subsequent therapy for clear cell cards, again the same things are there. There no need to give very deep explanation about it. You have to just categorize the patient and start the therapy. And subsequent therapy, one therapy fails, then the other therapy. Preferred regimen will be the cabocenative category 1, limited like that. I think Vijay will be the best person who can explain this in detail. But these tables are self-explanatory.
Sir, in the EU guidelines, they mention that if it is a favorable risk metastatic disease, then the survival is around 43 months, intermediate is 23, and poor is 7-8 months. Yes, sir.
Yeah.
So, sir, they include that is considering whether all the therapy is given, or that is when no therapy is given.
So it is generally given when the no therapy is given, because if you give the therapy, then it will divide the benefit of the therapy. Okay, yes. So suppose their favorable risk single METS, right? Yes. So he may live for it's a average median survival. It can be 2 year also, it can be 5 year also.
Yes, sir.
Okay, because it doesn't mean any patient who is poor risk, if you give chemotherapy, he will die within 7 months. Okay, yes. There's a median. This is a median survival is there.
Yes, sir.
Okay. Any other question?
Shashwat, you have got any other question to ask?
Oh, sir, other than that, sir, the cost of the therapy, sir, that we sometimes require for counseling, especially if you are practicing in the periphery, sir. So what will be the expected or estimated cost and the duration of therapy that sometimes the patient asks us?
So again, immunotherapy is costly than the TKI. And is that
Executive employee is going to cost you something like 3.5 lakhs per month. But if you see the same chart, if the patient is really poor, you can still use pazopanib and sunitinib, which are both available in India as a generic now.
so when sunitinib was launched, so it was very costly. After few years, when the patent is gone and generic drugs are available, so it comes in a few thousands rupees only.
And
But
this
at
drug,
present,
cabozantinib, that is also now available from Sun Pharma. So the cost will come only with nivolumab in that combination. Cabozantinib, nivolumab.
so Shashwat, your question was there na, about the therapy of survival.
Yes, sir.
So that study was done during the TKI era. Whether they use sorafenib, sunitinib, it is not clear. Okay.
Okay.
But 2 year of 2 years survival evidence is there. So it was with the therapy. I'm sorry for that. It was with the therapy.
Yes, sir.
So again, non-clear cell, because they are a rare tumor. So immunotherapy is the first line of treatment, followed by TKI, and if it not responsive. Okay.
Second
One
case.
more thing is one more thing, sir. If we get a biopsy done, sir, if a renal biopsy is done and it is showing sarcomatoid histology, so should we proceed with direct systemic therapy, or whether any role of cytoreductive nephrectomy? Because
So again, it depends, because sarcoidosis changes, right, and sarcoma of the kidney, they are two different things.
yes, sir.
And on biopsy from one side, it's difficult to differentiate it is a pure sarcoma of the kidney or clear cell has been mixed with the sarcoma. Right? So different sarcoma, you have to operate if it is operable. If it is not operable and multiple METS, then I don't think so there's any role of sudden nephrectomy or any chemo. Maybe the chemotherapy can be given, right? And if it is operable, better to operate them. Even there is a high chances of recurrence and disease further metastasis. If it is oligomets, it can be removed, but it has a poor prognosis. That should be counseled to the patient properly.
Yes, sir.
Okay, the next case.
Yes, sir. Second case, 39-year male non-smoker with no comorbidities and had a complaint with a palpable lump in left thigh associated with pain and difficulty in walking since 2 months. On MRI, erosive destructive lesion of left iliac cortex with a large associated soft tissue component on either side of iliac bone, and soft tissue mass of 6.7 into 5 into 6.9 centimeter was extending to the left acetabulum. Impression was large malignant mass of left iliac bone plus soft tissue component with metastatic external iliac lymph nodes was this. And on further examination, 4.4 into 5 centimeter vague mass palpable anterior upper thigh on the left side associated with tenderness was there. Underwent biopsy, needle biopsy, and metastatic, which was suggestive of metastatic poorly differentiated carcinoma, and suspected origin of the metastatic disease was kidney. So the question was how to investigate further.
So tell Shashwat or Dr. Miraj.
So I think a complete metastatic workup and a PET-CT would be required to.
So, do you think per patient having CT scan, bony mets and other things, having a doubtful renal lesion, PET scan going to change your management? As
We
I
can
think
estimate-
it was CT or MRI. What was done?
MRI was done, sir.
Okay, local place,
Yes,
local site only. Okay, fine. Okay, fine. So, before PET scan, anything you would like to do? Because the biopsy is not confirmatory for the renal cell carcinoma.
I think FNAC was done, sir.
It's an NC.
Needle biopsy was done.
Needle biopsy. Okay.
So it is a suspect renal cell carcinoma. In such cases, you should review the biopsy along with the immunohistology.
Okay, sir.
So they can differentiate the site of origin. Okay.
Yes,
And
sir.
if it is a if a biopsy is proved, this is the clear cell, this is the renal cell carcinoma, whatever origin, then you are right for the disease mapping. You can perform FDG PET scan. Okay, what was done?
So USG down pelvis or CT scan. This is the question.
So I think when we already have a diagnosis of bony mets involving the muscle mass and multiple sites are there. So FDG PET CT scan both are can be you can offer any of it based on the availability. You're not wrong in the examination. But if a CT is there, no harm. If it's FDG, CECT, and no harm in that.
So CT around pelvis was done. A large mass on left kidney, upper and mid pole, 6.6 into 5.2 centimeter was seen. Large paraortic lymph nodes, largest measuring 23 millimeter was there. The renal vein IVC normal, right kidney was normal. There was a large mass arising from left iliac bone of 18 to 15 centimeter with involvement of acetabulum. And CT thorax showed multiple bilateral lung metastasis, and bone scan showed left iliac bone, left acetabulum metastasis.
Okay. What next? How will proceed? What next?
Sir, we'd like to stratify the patient, risk-stratify the patient in the IMDC criteria, sir.
So based on CT, you cannot do. You cannot this thing. You can't do stratification of this renal mass. You need some blood test, no?
Yes, sir. We need the LDH, the platelets, the neutrophils, the calcium levels, sir.
Yeah, so you will not going to send individually. So you have to send calcium individually. LFT will include LDH, and CBC will include platelets and neutrophils, right?
Yes. Yes, sir.
Okay, then after you will stratify the disease. So what was that stratification? Was it done?
Sir, no, sir.
There will be blood test also, no?
Scenario, sir, that was done, sir. Only this scenario.
Okay, answer that's the very good question. Would you like to treat primary? Yes, why? No, why? For the bone, what?
Sir, this patient has a high metastatic burden, sir.
Again, there is no high and low in renal cell carcinoma.
Okay, sir.
So you can say multiple sites.
Multiple sites. Yes.
And few sites are unresectable. See the bony lesion, the iliac bone. Can you see it is resectable? And multiple lung nodules, resectable? No.
No, sir.
Iliac bone lesion, resectable? No.
No, sir.
So if you want to do nephrectomy in this patient, in what scenario you will like to do?
Sir, if the patient is symptomatic, sir.
Yeah. So only in palliative settings, if it is
Yes.
operable, then nephrectomy, palliative nephrectomy justified. Otherwise, you should not do.
Cytoreduction.
Not
And
at all.
Sir, also we'd like to know the exact histology, whether it is we are dealing with clear cell or
If a biopsy was done, ISC, that report will tell, because if it is not, it is unconclusive, again to re-biopsy.
rebiopsy.
Yes. Because suppose it is sarcoma with such multiple, what is the point in starting him chemo immunotherapy
Yes.
or TKI, right? So primary, okay. For the bone, what will you do?
Sir, if the biopsy from we took a biopsy from the iliac bone, sir. If it is inconclusive, should we go and biopsy from the kidney? Or should we
Yeah, so representative part in the CT, because if there is no necrosis, nothing, so then at least if first biopsy is unconclusive, then try to take multiple biopsies from different part, representable part.
Okay, sir.
Because if one biopsy is negative, if you take another single biopsy, chances of this remaining negative is more. So the best thing, either you take 2 biopsy from the metastatic side and 2 biopsy from the primary.
Okay, sir.
Yeah. And for the bone,
if asymptomatic,
and
calcium,
having back pain, then
denosumab.
denosumab, okay.
And,
You can just give simple painkillers and vitamin D and calcium and radiation therapy for the palliative RT.
this
Okay.
was one.
Okay. And if suppose this patient having some cord compression with that, then surgical intervention can be done for the improve the quality of life, not as a curative intent, but as a improving the quality of life.
Yes, sir.
Okay. Gaurang Shah, sir, anything else to discuss in this case or go to third case?
No, because see, what is happening
Yeah.
is that this type of cases now are very difficult to
Yeah.
get, first of all. So
Yes,
in
sir.
private now, when we come across such cases, forget about exam point of view also, but even in private practice also, when we come across such cases, we are also in dilemma. Okay, what to do? So the way you have explained and Ganesh has explained, it has become very clear that how we will approach, and this will help them even in the exam.
Right.
Unless and until examiner is very well versed with all these latest criteria, whatever they will remember after listening to your answer, it is more than enough.
Yeah, and but sir, if the examiner reaches to that part where he wants to listen something new, very new things, that the
Yeah.
candidate is passed already.
Correct.
Okay.
So this is a very practical approach
Yeah.
to all the different things. Even the last case, whatever the Ganesh has said, very important things. Fine.
Okay.
Okay. Next. I think the last case is there, no? Swastik.
Okay.
Swastik.
One minute, sir. 1 minute, sir. I'm, changing the slide, sir. Mm, 1 second, sir. Sir. So, third case is a 32-year male businessman with a chief complaint of pain left flank for last 1 month.
We can't see your slides.
1 second, sir. One second, sir. Sorry.
So Stick, you can log out and again,
Sir, I will try. Sir. Yes. So 1
or
second.
you stop sharing slides and again come back.
Yes.
So this metastatic patient, he will be started on TKI.
Again, TKI plus immunotherapy
Immunotherapy.
based on what the biopsy report is there. Gite sir said very rightly, everything is mathematical, right? If you know 2 into 2 is equal to 4 and 4 into 2 is equal to 8, right? It cannot be 12. It cannot be 6. You know the sequencing, and that you will remember when you practice it. Okay. Yeah, please go ahead.
Third case is a case of 32-year-old and 32-year male patient, a businessman with occupation, came with a chief complaint of left flank pain for 1 month and loss of appetite for 15 days, along with weakness for 7 days. History of presenting illness, asymptomatic for 1 month, left flank pain for 1 month, gradual onset, intermittent. Feeling of heaviness and dull aching pain was there. The pain was non-colicky, non-radiating, non-shifting. Relieved by medication, and there was no aggravating factor. Loss of appetite for 15 days and generalized weakness for 7 days. There was no history of hematuria, burning, micturition, fever, chills, rigors, pyorrhea. No history of nausea, vomiting, altered bowel habits, or bleeding PR. No history of headache, giddiness, palpitation. No history of swelling of lower limb and swelling in scrotum. There is no history of weight loss. No history of cough, dyspnea, and bone pain. No comorbidities. No past medical surgical history was there. Mixed diet. Patient consumed mixed diet. Has a loss of appetite right at present. Has adequate sleep. Normal bowel and bladder habits, no history of smoking or tobacco intake, history of alcohol intake occasionally, and there is no history of family cancer in the family. So to summarize the history, a 32-year male presented with left flank pain for 1 month, associated with loss of appetite and weakness. Going ahead to
yeah, go ahead.
Patient was conscious oriented, 2 time present person was 1. And patient was afebrile, vitals were stable, no pallor, signs clubbing, there was no lymphadenopathy or pedal edema. System examination was NAD, and on inspection of abdomen was flat, centrally placed and inverted umbilicus was there, no normal abdomen thoracic respiration, no scar, sinus, dilated veins, no visible swelling, no findings as such. On palpation, there was a ill-defined palpable lump in the left flank below the costal margin, and it was 10 into 8 centimeter in size, which was indistinct and firm in consistency. Moving with respiration, it was bilateral, bimanually palpable. There was fullness of of left renal angle, no palpable organomegaly. Rest was normal. And on summarizing the examination, a 32-year male patient with non-colicky left flank pain for 1 month. On examination, there was a left flank mass of 10 into 8 centimeter, bilateral, bimanually palpable, fullness and loss of resonance in the left renal angle.
Right. So the question is, how will you work up? Yeah, Miraj, you can answer.
First, we will do the routine investigation, CBP, CUE, creatinine level, and along with that, ultrasound of the abdomen. And the ultrasound is showing a solid cystic mass measuring 14.7 into 7.7 centimeter in the left retroperitoneal space. And the left kidney is not seen separate from the mass. So to further work this up, I would like to do a CCT of the abdomen, contrast enhanced CT.
Of the abdomen.
Of the chest and Abdomen and pelvis.
Always say the complete investigation, imaging on contrast enhance with the better contrast enhance abdomen.
Abdomen, pelvis and chest.
Correct. Fine. So Swastik, just show them the report.
CT was done, sir. Sir, actually the films were not, video is not working, sir. I'll go to the reports.
So go to the report and just tell them.
17 to 10 into 8 centimeter heterogeneously enhancing heterogeneously enhancing solid cystic left renal mass, multiple necrotic conglomerated lymph node mass extending from celiac axis SMA, precaval and paraortic regions.
So now, Shashwat,
Yes, sir.
yeah, this is a condition. Now what you want to do?
Sir, he's a 32-year-old male with suspected renal malignancy, left renal malignancy, multiple enlarged lymph nodes. Sir, I'd like to counsel the patient, and depending on the sir CT chest report also, I'd like to work him up for and obtain a metastatic workup, sir. And if it is going by the CT abdomen and pelvis, sir, it appears to be tumor with N1, sir. T2B N1. So I'd like to go ahead with a nephrectomy, sir. Radical nephrectomy.
And before that, you don't want to do any other workup?
Sir, a CT contrast enhanced CT chest, and I'd like to obtain, sir, and liver function test.
You don't want to see the bones in this case?
Sir, I'd like to get a LFT done. If ALP is raised, then probably I will also request a bone scan, sir.
See, like in first case, what Dr. Ganesh said.
Sir, going by current investigation, sir, doesn't appear to be a metastatic renal tumor, sir. But since there are multiple enlarged necrotic lymph nodes, sir, there is high possibility of metastasis, sir.
Okay,
At
fine.
CT can be done, sir.
So Mahendra, what is your take on this? Mahendra? I think Mahendra's internet is not working. So Ganesh, can
My
you help
mobile
out?
network. Gaurang Shah, sir.
Yeah, tell me.
I joined by mobile. Just I hear some. Did I miss something?
Yeah, it just show him the CT report. So it is a big 17 into 10 into 8 centimeter heterogeneously enhancing solid cystic left renal mass, and there are multiple necrotic conglomerated lymph node mass extending from celiac axis, SMA, and precaval and para-aortic regions. So the now next question is whether you want to do any other workup for the metastasis for the bones, or you want to do PET scan, or you want to do bone scan. Is it necessary, or one should go ahead with the surgery?
So, sir, on a CT scan, there are lung mets. CT chest was done.
We presume that it was done, but it was not present.
Okay.
So they are not
So
able
if,
to run this.
Right. So if we can, because celiac axis, SMA, paracable, so if this mass is operable by any mean, we can do multiple ancillary procedures and mass can be removed, then I think we can do FDG patients. This scenario, just we are not missing some small METS anywhere else.
So we should do PET scan. You are suggesting that we should do PET scan in this
Sir,
case?
biopsy proven papillary type 2?
No, biopsy is not done, no?
I saw the biopsy
now
report
it
from
is. Yeah,
papillary type 2.
ultrasonography.
Mass
Yeah,
was
yeah,
done.
yeah.
Okay, okay. So papillary type 2, sir, are they are also not aggressive, they're of aggressive behavior. So I think there's no harm in doing FDG PET in these patients. And also just to see the other Lynch syndrome, the other component of Lynch syndrome, the papillary type 2.
Sir,
Okay.
I have a question, sir. Sir, was the biopsy indicated in such a tumor, sir? Because it seems to involve almost whole of the kidney, sir. And it had multiple enlarged lymph nodes with a heterogeneously enhancing mass. Can we directly go for a radical nephrectomy, sir?
So again, there is the role of biopsy. If you go the indication of biopsy, where the diagnosis in the doubt, whether it is a TCC, whether it is a lymphoma, is it other thing, because generally, if any tumor involving or replacing the whole renal parenchyma, okay, along with the necrosis, certain necrosis, other thing is RCC. But some mass is purely solid tumor involving the whole kidney with the such mass. Lymphoma possibility can be there, because if it suppose that you remove the kidney and it comes as a lymphoma, right? You are in trouble.
Yes, sir.
Because surgical management is not indicated in the lymphoma.
Yes, sir.
And doing biopsy is not, you are not doing anything harm for the patient, right?
Yes, sir.
So again, biopsy, one of the biopsy indication is where there is a diagnostic dilemma. Okay. But again, if there is a 2 into 2 centimeter mass, which is radiologically more likely to be RCC, you should not do biopsy of those that lesion, right?
Fine. So
Yes, sir.
Yeah.
Because you are saying that because in this case the whole thing is involved and the renal kidney cannot be differentiated from the mass, it is advisable to rule out other pathology.
Yes, sir. Yes, sir. Because, sir, normally RCC, pure clear cell carcinoma, even papillary RCC, is not present with the such type of nodal mass involving the celiac trunk and SMA and the other everything like that. Maybe
Right.
ACC also can present like this.
Okay. Fine. So now, Shashwat, this is the thing. Now, what you want to do? So one thing is clear that in this case, if you do FDG PET scan, you are not wrong.
No,
because he said that there are chances that we don't want to miss even a small malignancy.
But if examiner specifically asks CT or PET scan, okay, you always go for the CT scan, because no guidelines this thing propose strongly to do a PET scan as a first investigation. Okay.
Yes, sir.
Yeah. Okay. So the next question is what you will do now?
Radical nephrectomy template based lymph node dissection, sir.
Okay.
Okay. So do you think it is very easy to remove nodal mass from the celiac trunk, SMA, and pararotic node and everything?
No, sir. Technically very difficult, sir.
Yeah. So what is your answer? What should be your answer?
Systemic therapy to make it more operable.
Okay.
Papillary RCCs or systemic therapy will not.
Again, there is no guidelines about the new adjuvant chemotherapy. Okay, so again, this should be the, again, this patient should discuss in the MDT, and it would counsel like that. There is no guidelines about it. If it is, you think so, with the minimal accessory procedure, the disease can come out. Definitely, this is the best answer. If it is not, if you think that a patient may need Whipple operation, or maybe pancreatectomy, and maybe duodenum is involved, then after counseling the patient, giving neoadjuvant chemotherapy, just see the response. If it is can be operable after the chemotherapy, can be also a justified answer. Okay.
Yes, sir.
But when there is so much of cancer load, is it not better to first remove the kidney and as many nodes, whatever are removable, you remove, and then you give immunotherapy?
Sir, what happened after even the chemotherapy? The patient morbidity is too much, because we do not know how much blood loss will be there during the surgery, and how much mass we can remove therapy now, and we see how much disease size reduces as a whole. It will guide us better to touch patient or not, because suppose that if we give chemotherapy and disease increase in size, then no point in operating the patient.
Okay. So you propose that first we start the chemotherapy, and then if it is
sir, if it is
well,
yeah, sir,
then you operate him and try to remove as much as possible, and then you can give again.
Yes, sir, better to remove. Yes, sir. But if per the CT scan, if disease appears operable with minimal accessory procedures, then it should be offered surgery, where we can achieve R0 with maybe some part of pancreas is removed, duodenum is but part 4 is removed, then end-to-end anastomosis, then we can go for surgery. If it is not, then definitely giving neoadjuvant therapy, assessment, and then surgery can be the feasible option.
Okay. I think this point is clear to all of you. Sashwat, you understood,
Yes,
now?
yes, sir.
Good, very good. Okay.
Right.
So radical nephrectomy with the para-aortic lymph node mass excision and block was done.
Yes, sir.
Great.
Great.
What next?
Okay, fine. So now the end block mass dissect when even the lymph nodes were removed. So next, what, Sashwat? Now what you will do?
Histopathological report, sir.
Histopath was suggestive of renal cell carcinoma papillary type 2 and PT3N1M0.
Okay.
So in this case, they have not given this chemo or immunotherapy, and directly they have removed the mass because probably they were able to.
They think it can be removed.
Yeah.
Yeah. Right. Right approach.
Fine. So Sashwat, next.
So what
this is
next?
all thanks to Ganesh Bakshi, all the 3 cases. So next, what, Sashwat, what you will do?
Sir, sir, actually in follow-up, sir, a PET scan should be done, sir, to evaluate any metastatic disease, sir, because that is the only thing that is remaining, sir. We have not.
So again, so again in this, if CT scan was done before surgery, please follow with the CT scan. If FDG PET was done before surgery, follow with the PET scan. Because PET scan is something sensitive. When they give an equivocal, some lesion is there equivocal, maybe SUV is 4.5 or 3.5. It will give some suspicion of recurrence. So whatever test done before surgery, always try to do the same test after surgery for better comparison.
Okay, sir.
Yeah.
So do you have
So
anything?
you would not like.
Swastik, is there any other investigation follow?
No, this patient does not have a follow-up because he if you see the histopathology, it was papillary type 2, PT3, N1 disease, and large lymph nodal mass. So technically, it comes into the criteria of the patients who should get adjuvant therapy. The
Okay.
adjuvant therapy data technically was in RCC with a very small number of non-RCC, non-clear cell patients. But in papillary, similar situations, you are supposed to give immunotherapy.
Okay.
T3N1.
Ah.
So this patient was not affording for immunotherapy. He took sunitinib. And after, I think, about six months odd, PET-CT has shown relapse. Relapse in the sense metastatic disease.
Okay. So in this case, Ganesh, how often you will do? Means when you get such a, either it is a metastatic disease, then you wait for 6 months, or it spreads very fast, so you should do 3 monthly.
Sir, T3N1, because of the N1, these patients, you are asking me about metastatic workup?
Yeah, in all these 3 cases when we have done, though surgery has been done or the
Metastatic
immunochemotherapy has been
workup
given.
has been done in all patients.
Yeah. So after that, how to follow? Means like in a normal nephrectomy when we do, and there is no metastasis.
Standard thing in a metastatic patient or a patient like this who is going to go on adjuvant therapy, standard follow-up imaging is usually at 3 months. 3 monthly rather.
Correct. So
and
that is what.
If you're putting the patient to a medical oncologist, they will always do that.
Correct. So that is what I want Sashwat and others to understand, that whenever there is a metastasis or such a mass, then it is better to do after 3 months.
Yes.
So usually patient is receiving some therapy or the other. So they are going to have a response assessment continuously.
So, so this patient will require the adjuvant therapy,
yes.
Correct?
It will PT3N1. N1. So these are the patients who should today refer to medical oncologists for adjuvant therapy because there is a better data.
Correct. And suppose the patient asks us that what is the, or the relatives, okay, what is the progression and what is the life expectancy in such cases, then what will be the answer? In your practice means basically, Ganesh, how you have seen them progressing and approximately what is the mean survival?
Life expectancy is different. Now this patient has begun with non-metastatic disease, which is node positive.
Right.
So particular patient, he has in 6-7 months, he has now got metastasis. But there is some treatment available. So life is not over like earlier we used to have RCC and metastatic RCC and 6 months to 1 year survival. So today they go on. But per se, papillary type 2 is an aggressive tumor for students actually. And metastasis from papillary type 2 is kind of an aggressive disease. So further management will involve a lot of things. It will probably involve a next genome sequencing study of the histopathology so that newer mutations or drugs are available for this patient.
Okay. Fine. So all these 3 patients you have given us, they were following up till end with you, or they are still surviving?
So they are still following up all these patients.
Oh, so this one of the cases from 2014, I think. So
that patient is not following up.
Oh,
but this patient is last case. They are following with a medical oncologist also.
Fine. So now we can assure them in, at least 2 to 3 years even if with the metastasis 2 to 3 years of life expectancy.
So it really depends. I mean, many metastatic patients I've seen, they have life expectancy of more than that also.
Oh, okay. Again, how they respond to chemo or immunotherapy, correct?
Sir, targeted therapy plus immunotherapy.
Right.
So chemotherapy is really rare.
Hmm.
And probably if we are not sure of the follow-up and all, it is best to let them follow up with the medical oncologist.
Yeah, I think all of us do the same thing. We, in such cases, we always say that they have to follow up with them only, and they decide the line of treatment. Fine. I think this has cleared our only thing is that chemotherapy. Vijay Patil was very busy, so he could not do it.
So maybe he'll join us next time. We'll speak to him.
Yeah, so we will tell him to give us some talk on that. So
Yes,
next
sir.
time, can we do? We have got one good case of testicular tumor. So next time we'll do that. Okay.
Yes, sir.
Okay, and we'll ask Vijay Patil also to join.
Yes, sir. Okay, good
Okay.
night.
Good night. Thank you very much for
Good
all
night,
the
sir.
good cases.
Good night,
And
sir.
excellent
Good night,
case.
everybody.
Thank you, sir.
Yes.
Good night.
Good night, sir.
Good night.
Hiren, Maheshwari, all good night.
Yes, sir. Good night, sir.
Good night.